So good evening, everyone. Namaste and Vanakkam, Namaskar, Sat Sri Akal, and very warm welcome to this session. I am so excited to be presenting young nurses. Starting today, we have planned for 7 webinars in this month. And this is in honor of Infection Prevention Week 2024. And since I train a lot of infection control nurses, I offered this to the entire group, and out of that, 7 of them came forward. We would like to avail this opportunity, and I am very, very happy they have done because tomorrow is yours. You are the ones who are going to run the show, and I'm very happy I'm able to give this opportunity as an entrepreneur. And so, very, very warm welcome to all of you. Just give me 2 minutes before I invite my presenter today. I just want to run you through a small slide. And just to inform all of you that this is not the uh, just the beginning of a series of free webinars. And Signia Healthcare, that's my company, in collaboration with Nurse India. Nurse India only technology platform for all nurses to come together. And if you are not a member of Nurse India, you can visit the website. If you do www.nurseindia.org, you can find them. You can log in there. There's a lot happening on that site. And I partnered with them to ensure that we are able to create the largest platform for nurses in India, so that one stop where nurses can find all kinds of information. So this is the plan for this month, and it is pretty, busy. I would say that 11th, that is today, we have non-ventilator as hospital-acquired pneumonia, then various topics that are coming up starting today, all the way to 31st of October. And today we are having Halle. The second name is very difficult for me to pronounce, so I'm going to ask her only to pronounce whenever I invite her. So this is the first of the 7 free webinars that we are conducting on different dates. Timing is going to be the same, 7 p.m. to 8 p.m. And the next one is going to be on 14th after 3 days. That's on Monday. That is all about extravasation. And the third one is on strategies to prevent infections in acute care settings. It is more of planning what we need to do in case you have to prevent infections in the acute care hospitals. Fourth one is about strategies to prevent SSI. And you will be meeting the speakers. And as the photo says, they are the ones who are going to be presenting that day. My job is only to facilitate and give them the platform that they need. And I'm really wishing that all of them will do well in the future. Then on 28th, we have prevention of CLAPSI. I think the previous one, cleaning and disinfection, environmental hygiene. Amandeep, she's now in Canada. She'll be doing the webinar from there. And then we have coming up, prevention of CLAPSI. And then we have last 31st October, we have prevention of VAP to be addressed by FEBA. And I really hope that all of you will come back every time and be there for all the webinars. And thank you for being here. And don't worry in case you are not able to make it because you are on duty or anything. All these webinars will be recorded and uploaded. And I am once again very, very grateful that I'm able to facilitate that. And I'm also very grateful that these young leaders, they rose up to the challenge that I have given to them. So thank you, each one. Many of the future speakers are already here, but you will see them individually on those respective days. So let me welcome Halle now. Halle, please switch on your video and audio. Hi, Halle. Good evening.
Hi, good evening, ma'am.
How are you?
I'm good, ma'am. How are you?
Excited?
Yeah, I'm very, very excited, actually.
I am super excited to be doing this because usually I used to bring seniors to do webinars, considering all those very expert and experienced people. I am very happy and delighted to be bringing you people to this platform because I believe that we have to invest in the future. Tomorrow is yours. And the today's world gives us this opportunity to do many things because we have the technology on our fingertips. So thank you so much, Halle, for being here. And let me first ask you to introduce yourself so audience can know you a little bit. And then I will ask you to get into the topic. Yep.
Okay. So a very good afternoon to one and all present here. First and foremost, I would like to thank Thankam ma'am for inviting me to this webinar. This is very actually interesting because this is Infection Control, International Infection Prevention Week, which I am very much interested in. And I am Halle. I'm Halle Tlangte. I'm currently working as infection control nurse in Gurgaon in Max Healthcare. And I graduated from Rajiv Gandhi University of Health Sciences in the year 2014. And after that, I did my infection control certification courses under Signia Healthcare, which was taught by Thankam ma'am in the year 2021, so which is around 4 years now. And then I have experience of around 10 years in healthcare. And in infection control, I have around 4 to 5 years as an ICN. So this is a brief introduction for me. Should we start, ma'am, or
Yeah, sure. So,
right? I think we have already been 7 minutes gone now. So I'll share my screen.
sure. I'm going to stay off the video, off the audio till you're presenting. And I will ask all the participants here in case you have any questions or queries, you can start putting it in the chat box. And today's topic is about non-ventilator associated, healthcare associated pneumonia. Now, this is one area that many of the hospitals may not be even tracking them, right? So I am very happy that, this is a focus area we must have because we don't know how many vulnerable patients could be picking up pneumonia while they are under our care in our hospitals. So to Halle, please share and enlighten. We have tried to keep it very basic and easy to understand. So go ahead, Halle.
Thank you, ma'am. I'll share my screen.
Sure.
Okay, is the screen visible?
Yes, good.
I'm audible, right?
You are audible. You are audible. Yeah.
Okay.
You are audible,
Okay.
ma'am.
Okay, thank you. So let's just go into the topic today. Today is we are going to discuss on non-ventilator hospital acquired in pneumonia. This is a very interesting topic because this is the very first time I've ever heard this topic is being discussed in a webinar. I work as an ICN for four and a half years now, but never have I heard about non-ventilator hospital-acquired infection because all we have talked about is ventilator-associated pneumonia, right? We might have all heard about VAPs, but we have never heard about NV-HAP, which is very interesting. And I also would like to ask Thankam ma'am if you have any inputs in between, or if anyone have questions in between, you can just raise your hands and then we'll stop in between. So let's just see what is non-ventilator hospital acquired pneumonia. So the non-ventilated hospital acquired pneumonia is defined as pneumonia that develops 48 hours or more than 48 hours after admission is not present at the time of admission. So this means that the patient does not have any infection at the time of the hospitalization. The patient will neither be present or it'll be incubated at the time of the hospitalization. This means that the patient will be either admitted because of, it can be your stomach ache, your fever, your headache or anything. The patient will not be presenting at the time of admission. So we will see how we will diagnose this, how we will see how we are going to manage all these things. Okay, coming to the source of NAV, NV-HAP, what are the sources of NAV-HP? These are very interesting because like I said, we have discussed on VAP, right? Ventilated associated pneumonia, but we have never discussed on non-ventilated hospital acquired pneumonia, right? So there are lots of items that we are using daily which can increase the risk of non-ventilated hospital acquired pneumonia. For example, we have sources like oxygen mask, which we are using it daily for our patients. If we don't clean and disinfect our oxygen mask properly, what we do is we just put them on and then we just keep it somewhere else near the bedside, right? That's what we do usually. And then whenever the patient needs it back, we put them on again. So that is a very, very bad practice where there can be lots of bacteria, infections, growth in it. And then we will discuss more about this later. There can be lots of airborne diseases where the bacterias, the microorganisms get infected in the things that we are using. So these are some of the examples. Your suction catheter, of course, suction catheter is what we use daily, same thing as oxygen mask. But what we don't do is we suction the patient and then we took it out, but we never clean it. We all might have known that this is a single-use catheter, right? We don't use it single-use because we all are concerned about our patients' financial status. We are more concerned about their billings, and also we never thought of all these infections that can affect our patients because of this. And then next we have nebulization mask, same thing. If we don't disinfect the aerosols in our nebulization mask, what happens is it stays there and then it will be causing infection for the patient, which will increase the same thing, the length of stay of hospitalization of the patient, and then same thing that will cause financial strain for the patient. Humidifier fluid. This is also very interesting because me and Thankam ma'am, we have discussed about this humidifier fluid. There has been lots of been questions coming up that whether we should be putting fluids in the humidifier or not, whether we need distilled water, sterile water in the humidifier or not, or some of them maybe there's sometimes in emergency cases they put normal saline, which is a very, very bad practice. The best practice would be when we use humidified oxygen is the best. So I would like to ask all of you to ask your biomedical team to put humidified oxygen in your hospital, which will prevent your NV-HAP. Next, we have bronchoscope. So cleaning of bronchoscope is very important. In hospital setting where there is bronchoscope, what they do is they do ultrasonic disinfection with that. But when we don't do that, what they do is, you simply put the bronchoscope in a patient and then you'll disinfect for 15-20 minutes and then put it back in another patient, right? That is also a very bad practice where we can increase lots of infection unknowingly, indirectly to the patient. And then we have like I've said earlier about airborne, right? So airborne, when we said airborne, the infection is present in the air. So whenever there is infection in the air, we don't know that which kind of infections are there. We cannot see with our naked eye all these microorganisms flying around. As you might have heard, at the time of COVID, we use N95 masks. We were equipped with all these kinds of PPEs. So now, since all these kinds of pandemic is gone, what we do is we just go out openly in air, which can cause pneumonia. Sorry. And then next we have undivided rooms in hospital. This is especially for the hospitals where we have undivided rooms, especially for patients who are sick. Isolation rooms are very, very necessary and mandatory for every hospital. When we don't have undivided rooms for patients who are infected, we infect the other patients and then we increases the cause of non-ventilated hospital-acquired infections. Okay, so symptoms. So these are some of the symptoms that we can watch out when we talk about pneumonia. High fever, cough. Sometimes it comes out with blood, thick mucus, fatigue, rapid breathing, shortness of breath, sweatings with chills, chest pain, loss of appetite, bluish lips, skin, nails. So these are some of the symptoms that will be seen in a patient with a pneumonia. So if the patient complains of these things, you should be aware, and then you should be alert that it can be a cause of pneumonia, which will be occurring inside the hospital. And then we have impact on health. So we have this impact on health data. This data is actually out of India. This data was collected by, we got it from Infection Control Today website. So the morbidity, it actually affects approximately 1 in 100 acute care patients, which means that out of 100 patients, 1 patients are already infected with non-ventilated acquired pneumonia. And then we have mortality. So mortality rate is about 15 to 30%. So out of all the patients that are affected, 15 to 30 will not make it up. So they die of non-ventilated acquired pneumonia. So this is a very, very dangerous case. And then the cost, of course, the cost will be increased. There will be financial strain for the families and also for the patient, and then it will also increase the length of stay of the patient, which will be, unnecessarily, we will be increasing the length of stay, where they have to stay more days than what they actually have to stay. And then we have prevalence here. So as we have discussed earlier, pneumonia non-ventilated hospital acquired pneumonia is the most common healthcare associated infection, accounting for 25.8% of all HAIs. Like I said, we have never talked about non-ventilated acquired pneumonia. All we talk about is ventilated acquired pneumonia. So as an ICN in a reputed hospital, I don't track non-ventilated acquired pneumonia. I track ventilated acquired pneumonia, but I don't track non-ventilated acquired pneumonia. But in this data, we have seen it contributes 25.8% of all HAI, which is not less. It is also it is also a very, very big contribution that made to all HEI's data. And yes, like I said, it accounts 65% of pneumonia cases in the hospital. So actually, 65% is more than the percentage of what we are actually tracking. So only 35% of what we are tracking is VAP, right? So this, we don't, I have, when I've learned about these things, I was also not aware of this. And I was very surprised that this is actually, more than normal VAP. And so the remaining 35% of pneumonia cases are actually, like I said, it is ventilator associated pneumonia, which we are tracking in our normal daily routine. And I hope all the ICNs who are present right here, I hope they do the same. They don't track NV-HAP, but they track only VAP, right? So let's see what all attention and sorry.
What happened, Halle?
Sorry, I'm just sharing the screen.
It's already there. You are already shared.
Acha. Okay. Uh, my screen is not okay. Now it's coming.
Okay.
Okay. So the tension and prevention from professional organizations uh, who do all this prevention from professional organizations like CDCs, they do all this attentions and preventions and awareness to all around the world. And CMS, Centers for Medicare and Medicaid Services, the joint commission. So these three organizations give attention and awareness to all the world. But however, so no national policies or mandates currently prioritize, they don't prioritize NVHAP for preventing, for surveillance, and also for reporting. Like I said, I'm an ICN, but I don't report it. So no one does. Nobody does reporting in VHAP. And also, unfortunately, it is the leading healthcare associated infection. It lags in national reporting requirements. And same thing, it is not included in CMS quality programs to pay attention for the performance, not even in India. So this is a very sad thing. Okay, so NVHAP suspecting bad fellows. Is it a bad fellows? Let's see whether it is a bad fellows or it is a good fellows. Why big organization have given awareness, but yet nobody is tracking, but nobody is reporting. Let's see whether it is a bad fellow or it is a good fellow. Okay, so we have seen that studies, there's lots of studies, research has been done on this, and then they have seen that actually NVHAP is related with sepsis. So what do you mean by sepsis? Sepsis is actually, when there is growth of unwanted microorganisms or bacteria in your body, right, which causes inflammations and all. So this actually contributes to sepsis. And then, according to Giuliano Baker, reported that NVHAP also sorry, reported that 36.3% of NVHAP cases with mortality rate of 25%. So this is a big number. And then also in large veterans administration study of over 1.3 million admissions in the year 2015 to 2020, approximately 9,000 patients developed NVHAP, which the rates was around 0.6%, and those 20% developed sepsis following NVHAP. So after they got this NVHAP, patient will develop sepsis. According to the studies, we have seen that they will develop sepsis, which can lead to fatality. So this means that NVHAP is exactly, I would say, a bad fellow, not a good fellow, right? Okay, so let's understand what we should do first and the foremost. We have discussed, so NVHAP is never addressed to the world, so it is not discussed, and then it is also not been tracked or not been reported. But as we have seen that it can lead to sepsis. What should we do? We should do that. We should address, we should report, we should make awareness around the world, not only around the world. We should start from our little community nearby, and then give afford and address people about this. And then what we can do in hospital setting is we should start with oral care. um, I don't know what they do in other hospital. What we do is usually we do oral care with chlorhexidine 0.2% every day, which is very helpful. But I've seen in 2-3 years that chlorhexidine 0.2% is not necessarily done. But I would say this is very effective. And mobility, of course, moving out of bed is very important. All doctors, after every surgery, they would suggest you to move out of your bed. This is very important. Prolonged bed rest causes your pneumonia, plus it can cause sepsis. So moving out of bed, uh, moving around, walking around, doing small little exercises are very, very important. And it is also very helpful. And of course, surveillance or early detection. Surveillance, what we can do is, you can send your diagnosis tests like x-rays, your sputum cultures, you can send all these things, and then you can monitor for your patient. You can do regular screenings for that. Early detection will also decrease your fatality rate, your mortality rate. And yes, of course, protocols, like I've said, nobody have set protocols, nobody have set policies on this. So we should also, it is important for every hospital to set and develop protocols for this, guidelines, and make SOPs for this. I would say, if you are an ICN, if you make up and bring up that you will need to bring a policy on NV-HAP in your hospital, will be very challenging, yet it will be very helpful. And next we have enhancing and prevention of treatment. I would recommend to, before every admission, you should check out for the symptoms, you should check out for the sources, you should do your cleaning and disinfection of your items that you are using. And then we have effective prevention treatment strategies. This will be usually done by your doctors. So if you can work together with your doctors, it will be good. And research and policy needs, like I've said, policies are to be made. You can talk with your unit head with this, or you can talk with your microbiologist to make a policy on this, because we need an awareness so that people will be aware about this. And I am sure that, like I've said, we don't usually talk about this, and I'm sure that most 50% of the doctors doesn't know about this topic, non-ventilated hospital acquired infection. I am sure 50% of the doctors doesn't know about this and are not aware about this. When we put tubes, when we put foreign bodies in our body, that's when we are alert about it. But we are not aware that normal patients, especially your vulnerable patients, like age more than 60, or your pediatric patients, your geriatric patients, and then your patients with surgeries, your ICU patients, these are very, very much vulnerable to get all these kinds of infection. Uh, so yes, I'm sorry. We are
Stop sharing, Halle. Can you just share so that you can conclude?
yeah,
You share
I'll
once
just
again. Yeah.
stop sharing. Um,
Are you able to share?
it's not sharing. Okay, I'll just keep it like this. So, ma'am, do you have any inputs in between?
Yeah, thank you so much, Halle, for that, deep dive into non-ventilator hospital-associated pneumonia. Very easily, you were saying NV-HAP. That's really nice. But I would like to invite any thoughts or, questions from the audience. Feel free to unmute and ask. So what I would like to just reiterate what Halle had already mentioned is that a hospital-acquired pneumonia, we usually associate only with ventilator. But we must understand that it can happen to anyone. And as Halle mentioned, we do have a very good percentage of vulnerable category patients. So I keep telling every time that when we identify vulnerable patients, the first thought should not be that these vulnerable patients can fall down. Most of the time, we think vulnerability is related to the risk of fall. It is not just that. They are at risk for everything for that matter. So, if you want to start identifying HAP, the best way for an ICN on rounds is to ask that if any patient has developed new fever. That's a good way to start, to ask on rounds if anybody developed new fever. And then look at the patient, whether the patient had, what kind of diagnosis did the patient come with. So is his fever new? How old is the patient? Does he have any cough? Does he have any chest, related complaints? You can ask the doctor to auscultate and see, because if there is no other explanation for fever, then the explanation will be probably pneumonia. I will give you the example of my own mother. She's 87 years old and she had a fracture of D7 after she had a fall. So she was with me only at home. Okay. So I knew that one of the complications of D7 will be because she has a lot of pain when she's breathing. So she will not breathe properly. So she'll take low breaths. So it can happen with patients who had even a simple surgery like cholecystectomy. So if they have pain in the upper abdomen, they will not breathe enough. And when they don't breathe enough, there is hypoventilation at the base of the lung. And that becomes an easy opportunity for any organism to go in and develop pneumonia. So I was continuing to, auscultate my mother, watch the saturation. Then I knew that her air entry to the base of the lung was getting worse. So I got an X-ray done at home and I could see that she had got, the basal pneumonic patches. So I had to get her admitted so that she will get her antibiotics intravenously, because I knew that at 80, 85, if I don't take care, she can deteriorate very quickly. So now this could happen to a patient who is in the hospital also. So becomes very important for us to keep our eyes and ears open. I think we are waiting for the day when some accreditation body will say that this is also a quality indicator. You better start monitoring. So Halle mentioned about 65% of all the pneumonias in the hospital is not ventilator associated. So unless we pay attention to track and measure, we really will not know what is the burden of non-ventilator associated pneumonia in the hospital. And if you have to call them hospital acquired, it is also important that the patient has not come with those symptoms of pneumonia. They will be excluded from the data. It will be after 48 hours if they develop any symptoms of pneumonia in the absence of ventilator. So they will be non-ventilator hospital acquired pneumonia. So in simple terms, you can call it HAP, hospital acquired pneumonia. The ventilator one is called as VAP. So you will know HAP and VAP. So it's a very important information for all of us. And this is being discussed outside our country and in depth. That is why we have got data from outside. We don't have data for most of the quality indicators in India for the country. So I think the discussion was very good. And it's a great awareness for all of us to know that hospital-acquired pneumonia can happen to anyone. Watch out for the very old and very young. And one more thing that Halle mentioned was about the mobility. This is something I would definitely like you people to pay attention, because more and more discussions are happening on early mobilization and early nutrition for all patients, including the ICU patients. So it is important that we have to pay attention in our nursing care plan. We should think that the patient should be mobilized as soon as possible. The recommendation is that even patients on ventilator, they should be mobilized out of bed, because that leads to better prognosis. So all this evidence is coming to us. We should be able to use that evidence in our practice. This is very important. I'm just trying to summarize what Halle has mentioned about, the topic that hospital, non-ventilator hospital-acquired pneumonia. So I'm going to stop here and ask the members here, thank you so much for joining, that whether you have any thoughts or any question. So please feel free to ask us. We
Good
would,
evening, ma'am.
good evening, yes.
I'm having one question, ma'am. So
Yeah.
I want to just clarify it. Suppose patient have the fever.
Mm.
So, like, otherwise we have to differentiate there whether this is non-ventilator associated pneumonia or we have the other infections. So, do we have to send samples from urine and from other things to isolate?
No,
That
there is,
patient has fever due to only pneumonia. X-ray is one indicator that we can see. Like,
yeah.
how will you differentiate?
See, the differentiation will come. Number one, we have to ensure the patient did not get admitted with any of those symptoms. They have got admitted with some other, diagnosis. Like in my case, when my mother got admitted, she is already getting admitted with pneumonia. So that will not be called as a hospital acquired pneumonia. That is, community acquired. We are going in with pneumonia. So the definition of hospital acquired infection is any new infection that is coming after 48 hours of
Data.
so that is one criteria. So what I was telling that after 48 hours, if you find a patient who is developing fever where the initial diagnosis was nothing. So for example, I would say that let's say a 84-year-old patient is getting admitted to hospital for dehydration. It happens in elderly people. So they have got electrolyte imbalance and they got admitted, and you are doing some fluid resuscitation, correcting the sodium, etc. Then maybe on the third day, the patient starts to have fever. So the initial diagnosis does not warrant that patient should have fever. So now you will start checking the patient, what could be the reason for fever. So what are the common sites of, infection? So you will see whether patient has any invasive lines, whether he has got a, peripheral IV line. So you would like to check whether that line is okay. Any problem there? If he has a urinary catheter, so you would like to check whether if there is UTI, sometimes it is symptomatic, sometimes it is asymptomatic. So all of them have got criteria. So when it comes to non-ventilator HAP, the pneumonia talks about, I'm sorry, VAP has got very clear criteria. Here, basically, you will be referring to the doctor, not necessarily the culture has to come positive. There can be X-ray changes, could be having any respiratory symptoms. And as Halle mentioned, I'm sorry, the awareness of this HAP is minimal in our hospitals. We don't track them. So only when we track and the doctor can diagnose that this patient has developed pneumonia after 48 hours of, admission to the hospital, that is the time we can consider this patient has hospital acquired pneumonia. I hope I have answered that question, Dr. Davinder.
I would
Yes,
like
ma'am.
to add on, ma'am. I'll add on to that question.
Sure.
So what happened is when a patient is entered to a hospital, the patient might have come without, cough, without fever. And when the patient comes with fever after 48 hours, representing the patient is representing with fever and cough after 48 hours. So you'll be doing all your diagnostic tests and all. And then if the for example, you send your sputum culture, if it comes positive, so you will take it as NH-VAP whenever the patient is without tubings, right? But if the patient is with tubings, you will be considering it as VAP. I hope that clears the question.
I think there will
I
be one more.
understood. This is only my query.
Yeah.
Okay.
I got the answer.
So there will be one more query, maybe some of them have. How about the patients with tracheostomy? If they develop pneumonia, will that be called as a hospital acquired pneumonia?
Yes,
Yeah.
ma'am.
Halle, what do you think?
Ma'am, can you
If
repeat the
patient
question?
has got tracheostomy,
Okay.
patient has got tracheostomy and
Mhm.
patient does not have any problem, But
Okay.
after the tracheostomy, after 48 hours, the patient develops signs of pneumonia. That will also be hospital-acquired pneumonia, right?
Yes, ma'am.
They
Yes,
don't come into the category of VAP.
Yes, ma'am.
Obviously, they will
That
fall in
is also, yes, exactly.
ventilator VAP. So very important for the infection control nurses when you go on rounds to look for these things. Don't only look at the regular CLAPSIs and the COTIs and the SSIs and the VAPs. We should be a little bit more open to see that what else, because there is another category of patients which we don't pay much attention, is the patients who develop sepsis inside the hospital. Vulnerable patients, they can develop pneumonia, which can later become sepsis. It can become septicemia. They can even lose their life. So these are the things that I think as ICNs you should keep your eyes open and discuss about it. So say, why don't we pay attention to this as well? Right? Yeah. Okay. Anybody else has any question? Thank you so much for all of you for joining. I'm really happy, close to 50 people came in, and this recording will get uploaded on the YouTube. So I'll be I am very happy that, all young nurses are, showcased in the webinar. And thank you for people joining in. And I'm very happy that, senior people like Dr. Davinder are coming and, attending these sessions being done by very young people. So I would like to request Dr. Davinder to say a few words of encouragement for our all young nurses.
So first, ma'am, these young girls are more energetic and they're so motivated for the patient safety. I must say, even yesterday I have seen that the young fellows, they have done wonderful for the infection prevention, and they're doing very good job, and very nicely she has conducted the seminar.
Thank you. Thank
Their
you.
hard work is just, we are looking at that because they are more tech friendly, they are more there are so many options here, they can making utilization of all these knowledge and everything, and you are the guide, you are guiding them, so they are doing wonderful. And ultimately when they disseminate this knowledge, it will be helpful to all the hospitals.
Yes, yes. Thank you so much for the encouraging words. And okay, there is a question that is coming up. How to clean the nebulizer mask? Nebulizer mask and regular mask. Halle, would you like to take that question or should I answer? Are you
I'll just read the question.
How to clean the nebulizer mask and probably the oxygen mask?
Okay. So every hospital protocols are different. What we do is in our hospital, first we clean with saline water. What we take is we clean with saline water first, the oxygen mask, and then we clean it alcohol swab with that, and then we make it dry off. So and then same thing with your nebulization mask. First you have to clean it in saline water, and then we have to clean it in alcohol swab and then dry it off. And before you use it, you have to keep at least 30 to 45 minutes.
Okay.
That's what we follow in our hospital, and every hospital is different. If you guys can also share if you have any different protocols.
I will share one very simple fundamental principle of cleaning and disinfection. So there are two parts to every equipment. First is called the cleaning part. Second is called the disinfection part. The cleaning is when you remove any dirt or any debris which is there, so which you can do with soap and water also. Not a problem. You don't have to have saline. You can simply, if I am using a nebulizer mask at home for my mother, I will just simply wash it and leave it to dry. And because it's for her, I don't need to even do alcohol at home. But in hospital, you can wipe, with alcohol, but make sure that it is completely dry before you use it on the patient. And another idea is not to hang this mask, etc., somewhere, exposed, and neither, you should put it inside the drawers. They both will just contaminate the things because they are not sterile ones, but at least they should be kept clean. So it's a nice idea to have a pouch in which you can, clean it, disinfect with alcohol swab. And since all of you we are talking about alcohol swab, one more basic information to all of you. Wherever you apply any disinfectant, whether it is alcohol swab or whether it is chlorhexidine or betadine, all my ICNs will know that I keep telling the mantra. Wherever you put, allow it to dry. Simple. Allow it to dry. So I hope, Nirmala, you got the answer. Thank you for asking the question. These are very practical question. Now, I want to ask the audience about something. What is your practice about oxygen humidifiers? How do you maintain them and what do you do in between patients? I would love to hear that from the participants, What are your practice?
Good evening, ma'am.
Good evening.
Myself, Raji, from Apollo Proton Cancer Center.
Okay.
We have the humidifier is the disposable one, ma'am. Every 72 hours once, it will have the pre-filled water, humidified water also inside. We'll just like that, we will connect to the oxygen. That's all, ma'am. Oxygen tubings will be there. We will connect, that's all, ma'am. Within 72 hours. That to have a validity open date. So we'll have 72 hours, we'll open. And once it's a 72 hours, more or less, the water level will be go down. Then we will discard it. Every 72 hours once, we will repeat the same. We are not using the, we are using only the single use, ma'am. It's a disposable one.
That's really interesting. So would you like to send me a picture? So 17th, when Rakshita,
sure, ma'am, I'll send you.
I will share the picture with the people who are going to attend. It's good to know that
sure,
because this is something I have ever seen. So thank you for sharing that information. Please share the photo of that apparatus and also just let me know what is the cost of it. It's good to know, right? And one is asking if there any isolation required. Isolation is only if the infecting organism needs any isolation. Per se, pneumonia does not need any isolation, but it's important to prove. So in a hypostatic pneumonia, pneumonia only means there is inflammation of the lung tissue. That is pneumonia. And what organism is infecting that? Hypostatic pneumonia happens because of hypoventilation. So unless there is a culture which says that this organism needs isolation, you don't need to have to give isolation. So now there's another question, Halle, I don't know, would you like to take that? How much period of time we can use the HME filter for the patients with ventilator?
Okay, so HME filter, we have to change it every 24 hours. So what we do is usually in the morning, we change it in the morning at 6 a.m. and next 6 a.m. we are changing the humidifier, HME filter, sorry.
Okay, that's your practice. Now,
yeah, 24 hours.
My side, as per the guidelines, HME filters can be kept if it is not choked. The idea is if the filter is looking choked, then you have to change it whatever time it is. Otherwise, you can keep it for slightly longer period because again, it is an expensive.
It can be, yes, ma'am. Till 72 hours, it's acceptable.
So some people are writing 72, yes. So there are two things that one keep in mind. It's important for ICNs also to know. If you change 24 hours for all your patients, the billing of the patient is going to go very high. And if you think that the HME filters are working, it is not choked, you should take it up to HICC committee and say that leave it open in the sense that you can change it 72 hours or any time before if the HME filter is choked. That is a better guideline than saying that change every 24 hours because I think that's not very patient friendly, right? Maybe the decision is being taken with the fear that, some HME filter might get choked, nurses might miss it. So we have to give that confidence that we know how to look at the HME filter. So a lot of people are answering that they are doing 72 hours. Usually it is 72 hours or any time it gets choked. That is the guideline. I'm really loving the question and the people are interacting. Very good. And some people are saying 48 hours. Okay. How will we manage if the patient is having NV-HAP? Obviously, that will be guided by the doctor. What antibiotics is required, oxygen if required, just like any pneumonia patient, that's the same care you will be giving, except that we are classifying it that this patient got pneumonia because the patient came to our hospital. That's why it is called hospital-acquired pneumonia. There is no treatment will not change just because it happened in the hospital. Treatment remains the same. I hope I answered that question. Thank you for asking those questions. So do we have any more questions? Otherwise, we are going to wrap it up. So can we ask all of you that did you find this webinar useful? Just put it in the chat box and give us some thumbs up or something so that our young speakers get motivated that they did a great job. Yes, we are getting some thumbs up. Good. We would love to have more people interacting. Very good. Thank you so much. I'm very sure all of you are all the young people interested to listen to the young people. Very good. Cigna Healthcare and Nurse India is definitely, committed to invest in nursing of tomorrow. So thank you so much, Halle. And please do not forget that we are going to have Rakshita talking about extravasation on 14th. That is on Monday. Am I right? It's Monday. Rakshita, are you there?
Yes, ma'am.
So you are coming on next Monday, correct?
Yes, ma'am.
We are going to talk about extravasation, another common problem, and she will be deep diving into that particular topic. So Halle, thank you so very much and God bless you and continue to grow and spread good news and do fantastic job for the sake of patient safety.
Ma'am, I think I should thank you instead for inviting me and giving me this big opportunity in this big screen and, discussing about things that we have never discussed before. So this is a very, very interesting topic. And then I hope everyone will take notes on this. And then I hope everyone will make, yourself grow into these things. And I would like to thank you, ma'am, for bringing up all this kind of topics, especially during Infection Control Week. And then, as we grow into this, it's a whole full month of Infection Control Week that we are going to observe. So thank you, ma'am, for all the hard work that you have done. I've never seen anyone doing so much hard work in this, webinars and then all this kind of in this digital area, uh, uh, India now. So I think I should thank you, ma'am. And then you are one motivation for us. You have inspired us a lot and keep inspiring us, ma'am.
Thank you. Thank you.
so
Thank you
much,
for
ma'am.
all the kind words. I feel motivated when you people rise up to the challenge. My responsibility is giving you the chance. And when people come forward, I did not ask anyone or compel anyone to do this. You people came forward. And I hope you will continue to read and be on the cutting edge of the latest knowledge. We definitely decided to deep dive into things that is normally not being discussed. What is the current strategies. That's what we are trying to discuss. So thank you so much for coming forward and taking that. And that is my only request to the current generation. Please don't be shy. Take up the challenge, do what is best to the best of your knowledge, and prove the world that we can make a difference. And I am very optimistic that you can make a difference. Okay. Take care and Shabak Khair and good night to all of you and see you on Monday. All right. Thanks, Halle. Bye-bye and
Thank
take
you,
care.
ma'am. Bye, ma'am. Bye, everyone.
Thank
Thank
you,
you for
ma'am.
joining in, everyone. Thank
Bye.
you, ma'am.
Bye.
Bye.